All right, so if you can't break the cell wall, our other mechanism of action is going to destroy the ribosome or inhibit the ribosome from making proteins for the cell wall or for cellular functions. All right, so it can't make the cell wall if you don't have the proteins, and our ribosome inhibitors are going to do that. Right, so we have macrolides, and ACE is the mnemonic to know the 3 macrolides that are in macrolides. Right, because remember they did get fancy, or they get less fancy when they start naming antibiotics. Now everything's called mycin. It's like that didn't help anybody, right? So we got zithromycin, clarithromycin, and erythromycin. So these are 3 macrolides, and macrolides are used for atypicals primarily. All right, so you see a lot of people on azithromycin or a Z-Pak, right? They have a pneumonia. Pneumonias can be caused by atypicals. They can also be caused by strep, so they might need to be on 2 antibiotics if they're super sick. Otherwise, they'll be on a Z-Pak, right? But it also covers a little bit of gram-positive, so you might be just fine with a Z-Pak. Depends on clinically how they look. All right. So what are some side effects? I'm not sold on this mnemonic or not yet, but motilin, it makes the GI tract move. Right. It really causes a lot of diarrhea. And erythromycin is actually used for patients with gastroparesis and a lot of like an alternative to metoclopramide. So it's going to promote GI motility. But then, just like metoclopramide prolongs QT, so does macrolides. So all your macrolides prolong the QT. So you would avoid them if someone has prolonged QT. Macrolides cause C. diff infection, so that's something to be concerned about. All right. Like I mentioned, COPDers are on this for life because they are at risk for atypical pneumonias, like with some of the mycobacterium related, or mycoplasma related, or the like. Okay. And then we got aminoglycosides. So aminoglycosides, the mnemonic is PNATs, just like mnemonic has a silent M, PNATs has a silent G. So P is plasmamycin. That's just for VRE, but the other ones can be used for other things. Right? So we have G for gentamicin, N for neomycin. Not used much anymore. It's only used for like bowel prep back in the day. Then we got amikacin, tobramycin, and streptomycin. Those are all aminoglycosides. These guys also prolong the QT. They're also otonephrotoxic, just like macrolides. And just like what other antibiotic that was a cell wall inhibitor is also otonephrotoxic? Vanco, right? These guys are workhorses for gram-negatives. These are great gram-negative drugs. They are going to eliminate gram-negative drugs, Pseudomonas being one of them. Right? Pseudomonas, if we look back at our table, is a gram-negative, right? So it could be used for gram-negatives. What else? So these guys you need to monitor a trough as well because they are what? Nephrotoxic. Usually if something's nephrotoxic, we probably can do a trough on it. All right, and then we got tetracyclines. We got doxy and tigacycline. Tigacycline is coming back because it is great against MDROs, right? MDR is highlighted in yellow there, but they cause prolonged QT. So that's a problem with these guys. So we got 3 QTs there. So I try to make a mnemonic. I'm not sure if you can come with something better. Just something that's antibiotics that prolong QT. I put my QTC as fat. All right. So M for macrolides, right? That's your ACEs. Fluoroquinolones we'll talk about in the next slide. All right, but those prolong QT, they're not great. And we got A for aminoglycosides, that's NATs, PNATs, and then we got tetracyclines, right? We have some other ones just on the bottom there just to finish it up. Antifungals, we mentioned before, they're A-holes to your QTC, right? So ACE holes, fluconazole, that's a prolonging QT. Bacterium does as well. Okay, and then we got this unique drug right here, and it's a special mixture just for MRSA and VRE. So it's a combo drug they give to eliminate these MDROs. It's usually top shelf liquor that you're going to use for like a really top shelf MDRO. Okay, and then linezolid, or Zyvox is the brand name. That's used as that's going to cover MRSA as well. It covers other things, but usually we use it for MRSA and VRE. Clindamycin, number 1 for C. diff. So someone's on clindamycin, they're going to have C. diff. It's like a 40 to 60% chance they're going to have C. diff, right? It's going to eliminate a lot of stuff, anaerobes, MRSA and such, but they're going to be high risk for C. diff. And then chloramphenicol, that's a chemotherapy drug. It's technically an antibiotic, but it was eliminated in the U.S. and it's still used worldwide though. The only reason we use it in the U.S. really is for like eye drops because your eyes don't have a good vascular supply, so you throw anything at it. All right. So these little diagrams on every page kind of summarize what we've been talking, so you can see where we were and where we're going and where we are. Right. So the ones that destroy the cell wall. Give me some cell wall destroying antibiotics. Vanco, right? It's a good one. Vancomycin is usually a great answer all the time, right? Vancomycin, those are Zocids of what kind of antibiotic? It's a beta-lactam, right? So here we go right here. So you got beta-lactams. They are our big category of cell wall inhibitors, okay? And then we're talking right now about ribosome inhibitors. They're inhibiting some fashion in the ribosome, right? They interrupt the top half or the bottom half or the like. All right, so our last group of antibiotics, these guys interrupt DNA or RNA synthesis. So they are stopping DNA from being formed in the bacteria, therefore the bacteria dies, right? Or they're stopping the RNA from being made. Okay, so we have fluoroquinolones. Fluoroquinolones all end nicely with fluoxetine. So if it ends in fluoxetine, it's a fluoroquinolone, right? So we got moxifloxacin, levofloxacin, right? Ciprofloxacin, and Cipro is usually used for STIs, but either way, these guys cover all the things. They cover atypicals, gram-positives, gram-negatives, pseudomonas, just about everything. They're great, right? But look at the side effects. They prolong the QT. They cause what else to happen?
Oh shit. Oh shit. Oh shit.
Your tendon to rupture, that's 6 weeks of a boot.
Oh.
Right? It sounds like a shotgun going off. Your Achilles tendon rupturing. So that's a hard sell to people. So your pneumonia get better, but you might have to walk for 6 weeks, right? And it's number 2 for C. diff. So you're gonna be pooping your pants for 6 weeks also, and then it prolongs your QT, so you might die. But it's a hard sell for fluoroquinolones, all right? And usually most hospitals have eliminated them, or they are not top shelf or bottom shelf, like get dust off the cobwebs because nothing else works. You pull the sensitivity report, everything is not working except for these ones. They're not getting better. Then we might pull out the fluoroquinolones, but they are not. They're highly discouraged to use, right? And we've got Flagyl. Everybody's on Flagyl. Metronidazole, Flagyl, right? So Flagyl is a strict anaerobe. It only hits anaerobes. Someone has a GI infection, Flagyl. Someone has a UTI, Flagyl. Someone has an abscess or fluid collection somewhere, Flagyl, right? So that is what it's used for, right? Don't drink Flagyl or eat Flagyl with E2H, otherwise you're going to be vomiting a lot, all right? That's not a good thing. Flagyl causes C. diff infection, ironically, and it's actually used for C. diff. So it's like which one came first. So but they're on Flagyl for something else, and then they'll get C. diff, or they have C. diff, and then they'll get Flagyl to fix the C. diff. So it just depends what side of the fence you're on when you're talking about that. So stop talking about fences. I hate fences now. Anyways, we got our next dude here is Bactrim, and Bactrim was invented in the 30s before the FDA. So the Bactrim came out, and kids weren't taking it. They said, hey, you know what? We'll make kids take it, make it sweet. So they gave Bactrim with sweetener to a whole bunch of kids, and like 75 kids died because they all got renal stones and went into renal failure. And so so the government said, we got to do something about this. We got to maybe regulate drugs. I'm just saying, right? So the Food and Drug Administration got developed in the 30s because of Bactrim, right? So kidney stones, renal failure is a problem, right? And also it's directly toxic to the liver, cause your liver to necrose, which is not great. That's called drug-induced liver injury, right? It also causes BM suppression, bone marrow suppression, not like just makes you constipated, all right? It's going to suppress the bone marrow, and your bone marrow makes what? Makes RBCs, makes platelets, and it makes white blood cells. So you have a bacterial infection, you get Bactrim, and now you're immunocompromised. Now you got another infection. So Bactrim is very, very potent, though. So it's gonna kill everything because it actually inhibits folate production, and folate is needed for DNA. So it's a precursor to those, to your different nucleotide bases. Okay. So fluoroquinolones actually work on the DNA also. Metronidazole, I didn't mention how it works. It's a Trojan horse. It's like, hey, look at this. This is cool, huh? And they get in there, and what unloads are free radicals. It's like little grenades. And they all come out, and they destroy the DNA inside the bacteria. All right, fidaxomicin is really only used for C. diff. It's a special new drug for C. diff. And then nitrofurantoin is only used for UTIs. So it's a medication when you see someone on nitrofurantoin, oh, you got a UTI. Cool. Right? So that's all it's used for. Okay. And then go back to Bactrim. So besides killing your liver and your kidneys, it also kills your skin. And it really doesn't kill your skin unless you're allergic to sulfas. So that's why I always ask someone who has a sulfa allergy before they take Bactrim and before they take Lasix, for instance, is also a sulfa derivative. Right, because it will cause your immune system to attack your skin, and literally your skin just sloughs off, and now you have a huge burn, right? So it's a huge sloughing of your skin. Your skin is dying, and it can cause all the things you talk about with burns, which you talk about next semester, but because of widespread dehydration, and that's not a good situation. All right, it's like, who's Stevens-Johnson? Why does it care about Stevens-Johnson? Right, so it's Stevens-Johnson syndrome, and that is SJS, or the brand name. That's the brand name. So the generic name is toxic epidermal necrolysis. So epidermal necrolysis is lysis of the skin with necrosis. So that's not good. All right. Another side effect of Bactrim is photosensitivity. So they should wear what? They should wear some sunscreen, right? Not sunglasses, sure, but sunscreen so their skin doesn't get inflamed, right? On the previous slide, doxy also has photosensitivity. All right, so those are your DNA, RNA antibiotics. All right, this is our last slide before we take a break. This slide encompasses everything we've been talking about so far, right? So we got skin and soft tissue infections, SSTIs, right? Those are they can be caused by CLABSIs too, but skin and soft tissue infection or CLABSI, someone comes in with a huge abscess and they're septic, right? What are some signs of sepsis? They got tachycardia, they got tachypnea, that's all you need really, but they might be in pain, but you would look to say, oh, they got a huge abscess and they got tachycardia, tachypnea, you got signs of sepsis. Let me give you antibiotics. And then you have to know that these certain antibiotics affect the skin, and that's usually gram-positives or gram-negatives, right? More commonly gram-positive like staph. And worst case scenario, that staph could be methicillin resistant or penicillin resistant, right? So it might be MRSA. And usually how you know it's MRSA is it's purulent. It's throwing out pus all over the place. It's nasty, right? That's usually a MRSA infection. Okay. So what covers MRSA? Vanco. Right? What covers gram-positive, gram-negatives, and maybe some anaerobes. So if they don't have an abscess, you just do gram-positive, gram-negative. So that's where we can start with something simple, a simple beta-lactam, but you go all the way up to Zosyn. You can even go up to cefepime or carbapenem if you wanted to, but so just a simple beta-lactam, right? It's really your choice, right? You could do certain situations. There's all kinds of algorithms out there about what's the best one to do, but really I just want you to know that I need to give something that is, worst case scenario for there's something skin-wise. I'm giving something that's gram-positive, gram-negative, and anaerobe because they might have a what? An abscess. Okay, so most common bugs, we got Staph epi, Staph aureus, might be MRSA. You could have some gram-negatives in there. You could have anaerobes and abscesses. All right, so this is just like a chunky, mild kind of situation. This is not like a huge, like we're not going to pull out all the weapons against this. If it gets worse, yeah, maybe, but usually we're going to start pretty simple. Like we're going to try something like ceftriaxone, right, to see if that works, right? Doesn't work, we can escalate, okay? And then pneumonias and UTIs. We mentioned that pneumonias and UTIs both have a community variety and a hospital variety. Which one's worse? Hospital variety. So you're going to expect the heavy-duty beta-lactams, right? You're going to expect the spicy, the extra hot, right? Caliente, spicy salsas for someone that has a hospital-acquired UTI or a hospital-acquired pneumonia. Okay. Pneumonias are usually aerobic, right? Because you're not going to see metronidazole flagell up in the lungs unless they had an abscess maybe. But 9.9 times out of 10, lung infections are because of something that's aerobic, right? So that's why you don't see metronidazole anywhere up on the pneumonia spectrum. Fluoroquinolones, again, as an outpatient, you might be able to get away with it, but it's a hard sell. So beta-lactams do not cover atypicals, so we have to add something. So instead of fluoroquinolones, let's give a beta-lactam and something that covers atypicals, and that would be like doxy or macrolide. And macrolides have what mnemonic? ACE, right? So A is for azithromycin, C is for clarithromycin, E is for erythromycin, and azithromycin is usually the one you see the most. Okay, so you're going to be on azithromycin and a ceftriaxone, or if they're really sick, they're going to go to the ICU or they're going to go to the hospital setting, be admitted, beta-lactam, right? But we're going to take it up a notch, right? Like Emil Lagasse, right? Remember that? That's a cool reference from 25 years ago. Anyways, you have you're going to kick it up a notch. You're going to make it more spicy, right? And you're going to make it, instead of just something like ceftriaxone, let's hit them up with a stronger beta-lactam. What's stronger than ceftriaxone? You can go another generation, go cefepime, or you can go to Zosyn, is stronger, or you can even go all the way up to hit them with a tank, which is your strongest beta-lactam, which is what? Your carbapenems, right? And what are your carbapenems? That's what you call medic, right? What are they again? Carbapenems all end in enum, which is nice, or penem. You got meropenem, E for ertapenem, D for doripenem, C for imipenem cilastatin. Right, so those are your carbapenems, right? And if someone's going to the ICU that's super sick, someone's going to into the hospital setting being admitted, they might have Pseudomonas, right? Pseudomonas is found in recently hospitalized patients. And it's found in like nursing homes, it's a hospital-acquired infection, so we got to cover for it, right? We got to cover for Pseudomonas, and luckily, cefepime and Zosyn do, right? So that's the idea. And then UTIs. So UTIs can be simple. And what's the two drugs we always give for UTIs, or only give for UTIs? That was nitrofurantoin, and we got fosfomycin. Those are only really for UTIs. Then we got other stuff, right? That you can get. Usually it's gram-negative because it's making its way from the bowel into the bladder, and it's really, really difficult for males to get this, right? 90% of the time, it's a female UTI that you're covering for, and it gets complicated when you talk about pregnancy and such, with like which antibiotics for pregnancy. That was OB. We're not worried about that right now. All right, for NCLEX, you have to know, like, don't give fluoroquinolones for someone who's pregnant. Like, what can I give them for? Don't give them. Anyways, we have we're going to cover for. Pseudomonas can also hit the bladder. So if they are super sick, we're going to hit them up. We're going to cover all the things: gram-positive, gram-negative, and anaerobes. So guess what? You've seen Vanco and Zosyn for everything. It's like that is going to cover a lot. So you're going to see Vancozosyn. It's pretty much applies to every single one of these, right? When would you not give Zosyn? When they have urticaria and a rash and breathing difficulties. It's probably not a good idea. Like from the Zosyn, then you would not give another dose of Zosyn. Okay, all right, and then abdominal infections. There's a lot of nasty things in the abdomen, so we want to make sure that we are covering for all those things. And the abdomen has anaerobes, so now our friend metronidazole is going to make an appearance, right? But guess what? Vancozosyn and metronidazole. You can be a little bit more conservative and give ceftriaxone, and if you have the few combinations, but we're going to focus on these ones, right? Also, the bowel has yeast in it, so we got to cover for yeast, right? We got to cover for fungi, right? So the common yeast is Candida, right? Candida albicans or Candidiasis. And if you want to cover for yeast, you can't give an antibacterial. You have to give an anti-yeastal? No, an antifungal. Okay. And what's the common antifungal is the A-holes, right? They all end in A-hole or ace-hole, asshole. So A-Z-O-L-E, right? So fluconazole, right? Ketoconazole, these are all fluconazole. They're A-holes to your heart. They're A-holes to your liver, right? They cause liver damage and QTc prolongation. So they're great, but they're not so great also. So we have to make sure if they're super sick, that we're giving antifungals also. When you're immunocompromised, you're going to throw those on no matter what someone's immunocompromised. Because worst case scenario, they could have a fungal infection, right? If you have all the antibacterials in the world, you didn't fix the fungus. Okay, so the last piece down here is extra spicy. This is a unknown source. We couldn't figure it out. We did all the things. We looked for abscesses. We did an X-ray to look for pneumonia. We did a UA to look for UTI. We did a CT abdomen to look for an abdominal infection. Didn't find it. So now we just do broad spectrum, right? The other things are broad spectrum also, but we're doing something that's going to cover everything. And what is everything? That's your gram-positive, gram-negative, right? Pseudomonas anaerobes, that's Zosyn. And then gram-positive, worst case scenario, that's Vanco, Zosyn and Vanco, right? But we do have a few other alternates, okay? Aminoglycosides is a really heavy hitter we mentioned for gram-negatives, so that's why you might throw that in there just for funsies, okay? You might see these little things about, and these things are kind of summarizing everything we talked about also. So, hey, here we have gram-negatives, this antibiotic covers it, right? Whatever makes sense to you. This is, this could be all memorizations, like you know all your antibiotics, or you could have little stories about them and organization the best I can to convey it to you, right? So we have to get antibiotics instilled to you somehow, and hopefully you don't get C. diff, but we have to get antibiotics into your brain somehow, and this is, I think, a good method to get it to you, all right? So you can understand how they work and their side effects and what they're needed for, right? When do you usually see this antibiotic? Zosyn is like a heavy hitter. It's been used pretty much for everything. Vanco for MRSA, right? So what else? These are other little mnemonics that might make sense to you, like what covers Pseudomonas? Zosyn, right? Cefepime does. So they're just taking the data from the charts, just put it all in one little spot. So you can look at this like 5 different ways, right? When you look at all this information, and it's like 3 different levels, because you have to know, is it gram-positive, gram-negative? Is it Pseudomonas? Is it this, or is it that? So that's how it is complex. And that's why when this is like base level, and when you get fancy, you're like with an MDRO, or these antibiotics don't work, that's where you get an infectious disease doctor to come in and say, move aside, right? And they're going to try to fix the situation.